Okay, welcome everyone. Thank you so much for joining us for our ACE and CPEN joint engagement lounge focused on improving eHealth literacy among cancer survivors. Thank you so very much for joining us. I'm Michelle Williams. I'm currently serving as the president-elect of ACE, and this was jointly organized by Devin from CPEN. So we're going to just start out by doing some brief introductions of our organizations, and then we'll get started with our first speaker. So like I mentioned, this is being jointly organized by the American Association for Cancer Education and the Cancer Patient Education Network. We encourage you to visit our websites to learn more about our organizations. And before we get started, we're just going to show brief videos that highlight some of our organization's activities and why, if you're not already a member, you should become a member.
Michelle, I don't know if it's just me,
Yeah.
but there seems to be a square in the middle of your screen. Is that anybody else seeing that? Oh, it's gone now. Perfect.
I joined AACE in 2008 when I was a postdoctoral fellow at Moffitt Cancer Center at the urging of my mentor at the time, Dr. Kathy Mead, since the annual meeting was to be held in Clearwater Beach, Florida. We organized a panel at that conference on barbers as prostate cancer health educators. We published findings from this prostate cancer education study in the Journal of Cancer Education, or JCE. And since then, I've continued to publish my research in JCE. And a few years ago, I was invited to join the editorial board. In 2016, with my colleague, Dr. Levi Ross, we co-edited a special issue of JCE on cancer prevention and control in African Americans. I first served on the ICEC Conference Planning Committee in 2014 and joined the Executive Council first as a member at large in 2018, and am now currently serving as Secretary of the organization. It has been a great experience getting to know fellow AACE members through the annual conference and by serving on the council. It has helped my career by serving as a regular reviewer of the journal and participating in the annual conference to hone my skills as a cancer education researcher.
All right, everyone, I'm Devin Poznansky. I am a member of the CPEN board and co-hosting this with Michelle, and I am just going to show a quick CPEN video, just as Michelle just did for ACE. So just give me a minute here. There we go. Okay, where'd it go? What is going on? Sorry, hold on a second. Being a pain. Technology, hold on, sorry. Okay. Can you see that? Okay.
My name is Amit Sahai, and I'm a professor of computer science at the UC.
Sorry. Okay, back to you, Michelle.
All right, before we introduce our speakers, I just want to encourage you all to continue the conversation that we start here going by joining us on ACE Connect. You do not have to be a member of ACE to join. We have several different discussion boards where we encourage people to engage in activities, share resources, ask questions, form collaborations. And we hope that you will join us. All you have to do is log on to connect.aceonline.com. And again, you do not have to be a member. And we encourage everybody to continue the conversation that we get started here. And also remember that our conference is going to be in October, and we're going to be in College Park, Maryland. And this is a joint conference between AACE-CPEN and the EACE. And it's our International Cancer Education Conference. So now I have the pleasure of introducing the two featured panelists for today. Our first speaker will be Tina Papadakis. She is the co-director of Cancer Self-Management Research Center at Princess Margaret Cancer Center, and she's also the Senior Manager of Educational Design and Knowledge Translation for Cancer Education. And then we also have another dynamic panelist, Ms. Loretta Herring, who is the CEO and co-founder of a community-based organization called Cancer Awareness Network, and they're doing amazing work around cancer and digital health literacy. And so without further ado, I'm going to turn it over to Tina.
Thank you, Michelle. Thanks, Evan. Just going to pull up my slides. Okay. Is this in the right view, everyone? I see a chat. Yes, thanks, Evan. Okay. Oops. Oh my goodness, I'm getting so far ahead of myself. Okay, I'm Tina Papadakis, and I'm so happy to be here today. I'm a member of both ACE and CPEN, and I've served on both executive boards and had an amazing time, and just find this group to be so wonderful. So I'm very happy to be here. And I'm excited to speak with you today about eHealth literacy and its effect on cancer survivors, and have conversations and learn from you as we go, and to hear from Loretta as well. So I've just put a few of the discussion points I'm going to cover on this slide for you to see where we're going to go for the next, I think it's about 13 minutes, not 12. So my apologies. For the next 13 minutes, we'll talk about these topics, and we'll have discussion after. So to start, I just wanted to say how much I continue to love the Pash-Orlow and Wolf causal pathway between limited health literacy and health outcomes. As a person whose career has focused on patient and provider education in cancer for more than 15 years, I just think it's amazing that this framework continues to be holistic and relevant 15 years later. So for those of you who are less familiar with the framework, on the one side, we see various factors that impact a person's health literacy, so kind of determinants of health literacy. And that's on the individual level. When you look at the middle, we get into patient, provider, and system level factors that impede or support health literacy. And on the far right, we see that all of these things impact health outcomes. And what I find I like about this framework is that it replaced an older deficit-based model that put the burden on individuals having low health literacy, and it reconceptualized health literacy as a system-wide problem, something that we all have a role in supporting. And this really was a strong call to action and a game changer in the field. It was a strong call to action for health literacy then, and it continues to be now. Being aware of individual, provider, and system factors that impede health literacy as educators, all of our work, or much of our work, focuses around mitigating barriers and building supports. In my work, these include things like adopting plain language as a universal precaution for all of the resources we develop. We co-create and co-design things with patients and families to make sure it's relevant and targeted. And we also provide training for healthcare providers in various competencies, including essential patient education and communication skills. Just gonna pause to see if there's anything I need to see in the chat. No, okay, good. Devin or Michelle, can I ask you if something comes up in the chat specifically for me to alert me? Because I don't see it very easily in my view. Thanks so much, that's great. So that's what we do as educators. As researchers, we contribute to new evidence streams and advocate for health literate healthcare organizations, systems, and supports. In short, like most problems, Knowing the causes and the effects of low health literacy has enabled us to design interventions and supports to improve health literacy. We're now at a precipice where eHealth literacy needs to be prioritized, and this is because it's critical scaffolding for eHealth. And as you know, eHealth is an evolving field at the juncture of medical informatics, public health, and business. It's where information is distributed and heightened through the application of information and communication technologies. It includes web and mobile-based tools and platforms, telehealth, health information systems and technology, artificial intelligence, applications, devices, and more. There's no question that we're all invested in learning how to increase the use of eHealth and the effectiveness of eHealth. This is because we know that eHealth has so many potential benefits, including quality improvement, cost savings, increased patient engagement, self-monitoring, and improved health outcomes. However, without eHealth literacy, these benefits will continue to only have a very limited impact. And so for a population as large as cancer survivors, eHealth holds particular promise. An unprecedented number of people are surviving cancer due to advances in early detection and treatment efficacy. But with the benefits of survival come detriments of treatment, including persistent side effects, emotional responses, and functional limitations. For cancer survivors, eHealth applications like patient portals and electronic patient-reported outcomes they've optimized care, improved patient-provider communication, and enhanced symptom toxicity assessment and management. So as eHealth continues to evolve, AI will also further refine algorithms from ePro data. Some authors have talked about how AI might better identify patients in need of intervention based on pros. Ambient intelligence also has a role in cancer. For example, wearable devices could be used to monitor body temperature and detect neutropenia in cancer patients, sending alert to patients to seek immediate medical attention and also notifying their cancer care team. So for cancer survivors, well-utilized eHealth will promote and will continue to promote health-related quality of life and longer survival. And at a health systems level, there'll be significant cost savings. So with eHealth, eHealth literacy is an essential competency. And on that note, I'm sure many of you are very familiar with Skinner's seminal definition of eHealth literacy from 2006 and its associated tool, the eHeals or eHealth literacy scale for validating or evaluating a person's health literacy. This is Skinner's Lilly model, which includes 6 components of health literacy. Now, despite the fact that it's really widely used even today, some researchers have argued that it's out of date because it hasn't considered the dynamic and social nature of eHealth resulting from the shift from Web 1.0, which you all remember, it's when the web was more static, where there were very few content creators and most of us were just consumers, to what now has been called the social web or Web 2.0, which emphasizes user-generated content, ease of use, participatory culture, and interoperability. There have been several attempts to update Skinner's original seminal definition of eHealth literacy. Here you can see 10. I've highlighted a few keywords here. I hope I didn't cross. I hope you can see them better than I can. They're a little bit crossed out, but to demonstrate the growing acknowledgement that eHealth has actually evolved, and it needs to include interactivity, connectivity, and communication in line with the capabilities of Web 2.0. So it's a much more complex set of skills. But one model that I keep coming back to is a reconceptualization of health literacy by Page and her co-authors. They posit that existing definitions and models do not quite capture the transactional nature of eHealth literacy. Specifically, in terms of Web 2.0, regarding information exchange, knowledge application, and message generation when communicating with others online. Well, think about this. Patients not only need to seek, find, appraise, apply, and act on electronic health information. Now they need to interface with multiple eHealth tools, including ePros, patient portals, virtual care and education platforms, and the internet. They need to understand that how these things are all connected and use them together, despite that most of these things are often fragmented. And they need to be able to engage with providers, family and friends, as well as other survivors within various communication channels, including email, social media, and health platforms. So eHealth literacy has become a significant challenge for individuals, providers, and health systems. And for this reason, this new conceptualization is up there for me with Pash, Orlow, and Wolf, because of its depth really gets at the complexity of the problem while showing us where we have opportunity to intervene. And for those who are aware of Page's transactional model for eHealth literacy, it was published in 2018, so bear with me, because for the next few minutes, I think it's worth a deep dive looking at each component of this model on the next 4 slides. So you can see here, I've kind of taken a screenshot from the model and put it in the corner and then built a bigger version of it here so you can see it better. So consistent with prior eHealth literacy models, a series of factors comprise the eHealth context. And these are task-oriented and user factors. So task-oriented factors include these 4 things. So channel, which is where the transaction occurs. So that's either social media, electronic health record, or email. The source of, or the identity of the communicator using it. So peers, friends, family members, or healthcare providers. The language used in the communication, be that your first language, second, third, or fourth, even plain language. And the modality of the message. So whether it's an image, text, or video. So these are kind of the task-oriented factors that impact a person's eHealth literacy. And on the user end of things, this includes technological determinants, such as, and these are very deep and very rich, I think. Motivation to use technology for health, access to technological devices, the type and number of technologies used to access health information, and individual frequency and preferences for using eHealth. All of these things form your technological predisposition. Knowledge determinants of eHealth literacy include the type and amount of health information you prefer and the amount of pre-existing knowledge you have about a given health concern. And relational support is described as the amount of support or perceived social norm in using eHealth. So if none of your friends are using it, or if your doctor is not talking about it, what is the impact of that on you? And last, there's personal factors, and these include demographic information about people. So things like education, race and ethnicity, socioeconomic status, and age. And these factors interact with one another to shape the transactional process of the eHealth experience. So you can see this is a little bit like Pash, Orlow, and Wolf, and very similar to much of what has been written about in the health literacy arena. It then goes on to talk about noise. So in this image, you can see the interactions between task and user-oriented factors produce external stimuli, which the authors have called noise. And these align and build on the determinants of health literacy. So I'll just go through each of these now. So over here, physical noise can include factors that hinder the whole experience, including cognitive information or information overload, and other things, including font size being too small, keyboard being too small, etc. Semantic noise is a disagreement between meaning on terms, which makes it more difficult to process. And that includes things like jargon, imprecise language, and getting conflicting information from different communicators. We know that one has been a big one in COVID. Psychological noise includes the effective response to the eHealth experience, which includes the nature of the urgency of the situation. So whether if it's a life-saving clinical trial you're looking up, or if you want to get more active and look for physical activity. The physiological noise can either be temporary or permanent. And these are things within your own physical body that might impact your ability to interact with eHealth. And that might include dexterity limitations due to things like neuropathy or your health status. So noise interferes with information transmission and accessibility among communicators, ultimately hindering their ability to access, understand, and transmit meaning to one another. The hierarchical triangle here represents eHealth literacy. So this triangle here is, according to Page and her co-authors, what eHealth literacy is. You can see that it mediates the relationship between the effect of noise on eHealth contextual factors and the degree to which an eHealth end user is informed or empowered. So I'll just go through each of these levels here because it is something that is a leveled competency. So functional eHealth literacy. So first of all, functional literacy, the ability to read and write, and health literacy form the foundation of eHealth literacy. From there, there's functional eHealth literacy, which are the basic skills in reading and writing and typing about health to effectively function on the internet. The next level up is the communicative eHealth literacy skills, which are the ability to collaborate, adapt, and control communication about health with users on social and online platforms and multimedia. Next is communicative eHealth literacy, that next is critical eHealth literacy, which is the ability to evaluate the relevance and the risks of sharing and receiving health information online. And the most complex of all is this new concept of translational eHealth literacy, which is defined as the ability to apply health knowledge gained from the internet across different ecological contexts. And last, you can see various health behaviors that impact outcomes resulting from users having translational eHealth literacy, starting with being informed and empowered and moving all the way down here. So informed and empowered eHealth literate patients are able to seek and find information. They take on proactive health behaviors. They're better able to communicate with providers, and they have better health-related quality of life. So this is back to the full picture again. So in order to scaffold eHealth, we need to scaffold eHealth, people need very high eHealth literacy. And I'll just actually go back one slide here for a sec. So in our context in cancer education at the Princess Margaret, one of the things that we do in our work with digital health development is investing in thorough plain language review and conducting usability and user experience testing with target audiences to reduce noise. It's our way of being accountable to make sure the things that we're developing are supportive and not creating a burden for patients at a time when they're not feeling well or battling a serious illness. So there's a lot of different ways that you can do this in different contexts. I did a quick look at the literature and found some more recent articles about ideas for how you can support eHealth literacy for cancer survivors. And I included some high-level notes about them here. I'm going to stop here and just give you a chance to read each of them, and looking forward to discussion later about some of the things that you might have done or things you've come across. So I'm going to give myself a good 10-second count to let you read. All right, and with that, I will conclude my talk, and thank you so much for your engagement, and looking forward to hearing more from Loretta and from you when we move into discussion. Thanks.
Thanks, Tina. That was great. I don't think I'd actually seen that model by page and all before, so appreciate sharing. I'm going to go and read that one. I'm going to hand it over to Michelle, who will introduce our next speaker. Michelle? Michelle, are you there? Apologies. I'm not sure where Michelle is, but I see that we do have our next speaker. Maybe we'll just give Michelle just a couple more seconds to see if she pops on, because she was going to introduce our speaker. Sorry, just give me one. Okay, I'm not sure. Michelle maybe had to step away. So I'm going to let our next speaker introduce themselves, because I do not have the information to do so. There's a learning. Maybe the co-host will share the information. So yes, please go ahead to Miss Loretta Herring. Is that right? Yes. Sorry, I don't see. Oh, there. You're up as Michelle. There you go.
That for some.
Oh, no, you muted yourself. Can you unmute yourself?
Oh, I'm sorry. Yeah.
Perfect.
Yeah, I'm Loretta Herring. For some reason, Michelle's name is on my picture here. I'm not sure what that's about.
Oh, now
someone changed it
for you. Yay.
Then
okay.
I saw a note from someone say they were in an ice storm in Austin.
Oh, someone just said they were late and they just was sorry they're late. They just
Okay,
hopped on,
okay.
so, yeah. Yeah,
That
we'll
don't
monitor the
confuse me.
chat in case anything comes up, and I'll let you know if anyone has any questions while you're speaking, but most questions will come after. So I'm going to let you introduce yourself.
Okay. Well, my name is Loretta Herring. I'm in Birmingham, Alabama. And I'm glad to be here. Thanks, Michelle, for inviting me. I guess what she want me to do is talk about our telehealth program here in Birmingham. We were able to develop a project that was able to assist senior cancer patients with having effective communications with their healthcare providers. And what we found is that when we got forced into this virtual world during the pandemic, a lot of our seniors didn't have even the emails or the devices to communicate with their healthcare providers. And as I was listening to, I said, Tina, I thought about all the struggles we went through in developing our program because we did not have access to a lot of the tools or the research, but we just saw that there was a great need. And the need was so great because in the underserved communities, a lot of times, not only did they not have the devices, they didn't even have Wi-Fi. And so we had to develop a program that addressed the needs of our people that would help them to be able to be more effective in their communication. And so we pulled together a team, first of all, and I see Sanford James is the one in Austin who is also part of our team in developing our project. And so we got this group together and we say, this is what we need to do, and was able to get the funding to allow training for, we call them TEs, telehealth educators, where we actually sit down and train them how to go into the home to teach the literacy, computer literacy skills. We also found in our community that a lot of people didn't know the jargon. And so when you start talking to them about putting things in the address bar, say stuff like, where's your cursor? They didn't even know the basic things, right? And I remember one of the young ladies, senior persons that I talked to during the early stages of trying to develop our program. I was sitting with her and I was telling her what the mouse was, and immediately she started looking around the floor. I don't have a mouse in my house, and I'm going, not that mouse, the mouse on the computer. So a lot of things we take for granted, and we take those things for granted because we know them. We know the science of it. We know the technological part of it. But most people in the everyday world don't even know what you're talking about when you start talking about those things. So we had to get a group of people that had the patience, first of all, to talk to senior people in a language they understood. And so once we got those people trained to go into the community, we actually allowed them to set up a relationship with each client that they would train. And then once they set that date and scheduled the training for them, we were able to monitor them on our tools on the computer, like maybe Google Sheets or Teams or something like that. And so we collected all the data we needed to execute our project. And it was so successful during the pilot that we got funded again to do it. And so we're actually still doing it. This is our second year that we are actually launching this program again here. And we are still struggling with getting people to accept the project. Those senior people, you have to take into account that a lot of times they have so many other things on their mind, and computers like the last thing they want to deal with. But we know the significance of them learning technology because we're in this virtual world. And so when you're dealing with senior people, it is so hard to convey that to them, that this is a part of the world we live in now. And it's time to reinvest yourself, to really learn how to use the tools. And so not only do we train people to go into the home and teach them one-on-one, we also leave with them tools they can use after the training process is over. About maybe a third of the people that we included in our program did not have Wi-Fi. And so we had that built into it. So we had to actually give them that device that had the Wi-Fi capability, and then we would actually service them for a couple of months. Now, our program is designed to help people in that population become self-sufficient with using technology. And so in our motivating them, we make sure we highlight their achievements to get their parents involved, their family members involved. And so what we found is that when we do it that way, their families and their grandkids were so impressed with them learning how to use the technology. Most of them went out and bought it for them anyway. And so that was a good thing for us. So that is pretty much what we do with our project here in Birmingham, Alabama. And so I'm just excited the work we're doing and how it's making a difference in the lives. A couple of things we did, we talked to the university, we got them on board because the medical community is who's going to benefit from this, right? And so we had to make sure we understood what their needs were. And so we trained according to that. And so it's just been a big success for us here. And we're going to continue this work, hopefully, as the months move on. So with that, I'm not sure what else you need me to share, but I'll take any questions you may have or any comments you may have, just let me know what they are.
Thank you, Loretta. We had two comments in the chat that people can read. Someone commenting on how, community engagement at the local level is so important. So kudos to you. And also a comment about meeting people where they are, as opposed to trying to get them to come to you. So that's excellent. I'm going to open it up.
That was actually what we found. I'm sorry. That was one of the things we found that was so different about our program, because when we looked around, most of the programs dealing with telehealth or eHealth, you had to actually go to a place to learn to use the device. Even in this area, the ones they have developed, you have to go to a center or you have to go somewhere. Where this one, we actually went into the home and sit with them one-on-one and taught them. And so how do we recruit? Very good question. Our recruitment effort came from, number one, word of mouth is always the best way, right? But we have in this area, what we have a group called Positive Maturity. So we use that pool of senior patients. We also have AARP chapters, which I'm a member of. And I actually tapped into those groups of people. Then each of the major hospitals have what we have support groups. So there are cancer support groups throughout the community. And so when you tap into those, you were able to find another pool of people that we were able to service. So it's a lot of groundwork. It's a lot of health fairs. It's a lot of speaking, but it's a lot of fun because you really get to know the people. And so when we deal with the actual hospitals and go into the doctor's office to share information, they sometimes will allow us to do that. And sometimes they would, not want to share, but that's okay too, because we were still able to get the numbers that we need and service the people that was needed. The telehealth TE peers to seniors will do more younger individuals. We've found that with young people, they didn't have the patience that our clients needed. We tried teaming college students up, and some college students, it worked well, those who had a background of working with senior people. But even in my family, guys, with my grandkids, they would take my device and fix it, but they won't show me how to fix it. And so that's the part we wanted to get past. We wanted to get beyond that because we want to empower these clients to do it for themselves. And so I'm just excited. Thank you.
There's another question, Loretta, in the chat from Dottie. Do you follow up with these patients to see if they are able to continue working with the technology after the lesson? And is there support for them when they have difficulty navigating electronically?
Yes, we do have a number they can call to find out more about us. We have a number they can call in to ask questions. And then all of our people that we train, our TEs, leave their personal information with them too. And if they can't find the resources they need, we would deal with them one-on-one when it comes to that. So yes, we don't just leave them out there. We actually go back and evaluate each client in 3 months, and then do another evaluation in another 3 months to see where they are. And so far, the success rate has been pretty good.
That's great. We have a couple more questions here. They're popping up. Lou has a question. Have you written up your program anywhere? Or is it just still in early stages?
It is actually in early stages. I've done a couple of publications. Bristol Myers Squibb did a story on us about a couple of months ago, and they're getting ready to do a video of our project. And so that should be coming out in their digital magazine. But to actually write the paper up, no, I have not done that yet.
Great, thank you. Are there any more questions or comments? You know, has anyone done something similar to Loretta or any other eHealth initiatives at the organizations? Feel free to comment in the chat, or just you can unmute yourself if you want to speak up.
If you haven't and need my help, just give me a call. I'll put my information in. Oh, Harlem shares. Okay. If you need me to come and help you with setting it up, I would be glad to do that. You want me to just give my contact information here? I can do that. You can contact me at info@cancerawarenessnetwork.com, or just go to our website, Cancer Awareness Network.
Great, thank you, Loretta. And we can probably have that information also in our follow-up email after the.
Okay.
I just got to call out loud. This is Dr. Sanford James. I'm here in Austin, Texas, and I got to give some kudos because Loretta and I worked together for many years. The work that she's doing is on the ground, and I think that's something that's missing in cancer care. A lot of times we think in terms of systems, but we don't think about how the system impacts the people. And so I really want to give kudos to her and her organization, which I'm so glad to be working with. The project was very innovative because it came during COVID. And Loretta says, oh my goodness, Sanford, we have to do something. And she came up with this idea. And I said, wow, okay, let's do it. And I say that for everybody on the call. I'm not sure what your background is. My background is in cancer care. I'm the chair for the AACE Health Equity Outcomes Committee. And one of the things we emphasize is the need to do more real community engagement. And I could say to everyone, because I know this organization here, which I'm familiar with, does community engagement. But I think one thing that we miss, we don't engage those networks who are already working in the community. We kind of go and we say, I have an idea. And I would suggest that we go and just pay attention. So Loretta and her recruitment, she had a very innovative way that she did it. Her board is very involved. The board members are local. And I say this because I lived in Birmingham, and I had a chance to work with her in our church and other stuff. And she sets an example, ladies and gentlemen. You need to be modeling her model. So I got to say hello, Loretta. I'm sorry I'm late, but we're okay. So I just want to say that, and hello.
Thank you, Sanford. I really appreciate you being on and sharing that information. You're such an encourager. I thank you.
Thank you,
Let's
Sanford.
talk.
Oh, yeah, go ahead. James has a question for you, Loretta. He was asking, can you talk about your main success indicators?
The main success indicators we have is the surveys that we use for modeling our program. We actually do a couple of evaluations, one at the beginning to determine their knowledge, and then the other one at the end to determine our success. And all of those has been pretty much positive, much in the 80% percentile. We this is such a new concept for that age group, that population that we target, and they are so excited to learn. And you think about how kids are excited to learn. Well, guess what? Seniors are excited to learn. So those are the numbers that we have that we really, really are proud of that.
Great, thank you. I have a question. This may be more for Tina. Tina, you talked a lot about the sort of the theoretical framework and stuff, but from a practical point of view, I know that for our organization, healthcare providers tend to be the main users of our website because they're looking for cancer management guidelines or things like that. But we have so much patient information on the website. And this, maybe ties in a bit to Loretta's theme as well, that many people with cancer are older and maybe less familiar with technology, or maybe rely more on talking to their doctor than going to our website. But I wonder, first, Tina, and then maybe Loretta, how you can speak to how do we drive people to that information? How do we get their attention and get them to use it? What can we do to make that easier for them? Because there's a wealth of knowledge electronically that many patients aren't accessing.
Thanks, Devin, for the question. I'll be interested to hear Loretta's take too. At Princess Margaret, I don't think we're good at it. We have all these amazing systems, online portals, online rehab, online cancer classes, ePros, digital education prescriptions, website, one of the biggest patient education libraries in Ontario. And they all live in their own little silos. We have made an effort to put all health information for patients on one web page, but there's no conversation about how to use them and how they work together. And that's something that we really need to build priority in doing. So we don't say, there's now a new patient portal. The patient portal is where you find your, information about your test results and your appointments. But you also need to use that with the library. So if anything comes up in the portal you don't understand, you can look here. And so we don't give the instruction the way Loretta is talking about, where you do that end research, or what's it called, the last mile. When you go the last mile and make sure you finish the job. We make the goodies. We do a lot of internal validation testing, user experience testing, but then they kind of live there. And so I think there's work to do there for us. We also did a big health literacy audit of our webpage to look at the language and like the word level and the user experience of the webpage, because those small semantic distractions really take away from a person's ability to jump in and find out what they're looking for. So I think there's like a love and attention to the detail of getting the intervention right and testing and validation and building it with target audiences. But I think there's a bigger conversation. And I think this is where a lot of places fall because it's way harder. How do we make them work together? And that's where I see a big drive, at least in our next few years for our strategy at Princess Margaret, will really be integrating and making it an ecosystem instead of siloed eHealth goodies. Yeah.
Well, I think what you're saying is true, Tina. One of the things that we know is that we have to educate people. All of this is mute if people are not educated about where to find information, not just where to find it, but how do you go about finding it? When we started setting up our program, one of the challenges we came across was that the university here has portals. I use my portal all the time for information. Anything I want to know about me, I just pull it up. But each hospital has its own system, right? And so we had to download on the tablets, the devices we were using, whatever their system was. The patient, the client did not know how to access that. And then if you tell a older person, let's say 90, 85, 90-year-old, you have to set up a password. And they don't want to remember that password. And you tell them keep it in a secret place, write it down, but don't show it to nobody. That's not true. That's not going to happen. They're going to show it to somebody because they don't remember where it is. And so it's those kinds of educating that we need to do to our public, regardless of the age group that we're talking about. Unless we educate the people, and most of the works that we have and the systems that we have, there's no education component to that can reach that individual person. Even myself, when I started looking at doing the telehealth service, the reason I did it, because when we went into the pandemic, everything got shut down. And my doctor, my nutritionist said, we're having a meeting on Zoom. I'm going, what's a Zoom? And then once I figured all of that out, and if it took that long for me to figure it out, can you imagine what it's taken for the others? So we just don't put enough finances and support in educating our people. We just don't do it. We have all these great ideas and we have all these great systems, and everybody gets lost in it. And then you got these clusters going on at the different hospitals. And so it just makes it very hard for the individual to access that. Yeah.
And I'd add to that, something that I've fallen into a lot has been trying to develop intuitive user experiences so that you don't have to train people. But I think that there's a flaw in that too, because when we go for intuitive design or replicating common designs, we're assuming people are online. And so I think, it's been really great to hear about your project, Loretta, because it's really added dimension to a lot of the work that I've been reading about. Yeah.
There was another question in the chat. I'm not exactly sure how it relates to eHealth literacy. From Shelley, it says, do you think that doctor waiting rooms for cancer patients should read out a patient number instead of a first last name to preserve privacy?
Well, I don't even understand the privacy thing anymore. I think privacy went out the door when the pandemic came in. So
yeah, it's
I don't know how to answer that.
Are there any other questions from anybody on the call? Anybody want to share anything that they might be doing in similar areas? Michelle, did you have any questions? Oh, sorry, go ahead, Tina.
That's okay. I wanted to share actually a case study with you. It was kind of interesting. At the Princess Margaret, there was a very successful rehab program for cancer survivors. It was so successful, and it was in person, that they actually started having to triage people so that only the absolute sickest of the sick would be able to go to the rehab program. So that rehab and survivorship group approached my team in cancer education to build a digital version of this big rehab program. And I have to say, it's been an incredible experience because we built it before COVID, but it became the go-to standard during COVID. And when we were reviewing the engagement data and looking at what the impact of it was, I was like, what is this? We did all this beautiful work building these incredible modules, plain language, plain design, inclusive design, and people aren't doing them. They're short, they're sweet, they're amazing. I learned so much, like what's wrong with them? And we did testing with actual cancer survivors. And then, so we did an investigation and we found out it was the implementation that failed. There was no cohesive conversation to support it. So the health exercise coaches that would coach people once a week about what they learned and follow up on their exercise never mentioned the education component, never talked about any of the incredible online resources. And so to the patient, I mean, I can't even imagine what that felt like. You're not talking about a connected program, you're talking about different parts based on your professional responsibility. And so I wanted to throw that in there again, because it was huge learning for us, which was, well, when we collaborate as educators to build something, we actually need to be accountable to the implementation and follow that product through, not just, which we do with online monitoring, but we hadn't actually built the implementation plan. Yeah. Another lesson learned. It'd be really interesting to hear what other people have been up to in their environments. It's such a good representation from different spaces.
Yes, we have about 9 minutes left, so still some time if anybody wants to share anything that they may have done in this area. I mean, it's been 2 years of a pandemic, and I'm sure lots of eHealth innovations have happened.
One of the tools in this, because we was able to partner with them with our program, is called Patient Empowerment Network. And they have a digital Sherpa tool out there, a module that patients can go in and use to keep the training fresh on their minds. And it just helps to become more computer savvy. And so we always recommend that to each of our clients. And they even get a certificate after they finish doing all those 10 modules. And they sent us a copy of it. They're so proud of that. So there are a lot of tools, like you say, that's out there. We just have to make sure people are taking advantage of them.
Sounds like you really nailed your audience there, Loretta. You really, they got the certificate and they're so proud, and you really tailored the learning to them, which is amazing.
Thank you. Sorry. We
Oh,
can't
Michelle?
hear you.
Yeah, we can't hear you, Michelle.
You need to unmute yourself.
I think you're unmuted, but maybe it's your earphones. No, you can't get it to work? Okay. Does anybody else have any questions before we wrap up today? Okay, well, I want to say a big thank you to both of our speakers, Loretta and Tina. Thank you so much. This was very interesting. It's such a relevant and timely topic, and I think something that everybody is probably struggling with on some level, and how best to address their patients and getting them to use the technology and all the wonderful things that we're developing. So thank you so much. We may have to have Loretta back in a year or two to hear an update on her very interesting project. So thank you so much for joining us. I believe there will be probably a survey sent out after this to all of you to evaluate the engagement lounge. Correct me if I'm wrong, anybody. But also we will send out Loretta's contact information for anybody who has any questions. And yes, thank you so much, and have a great rest of your day. Bye for now.
Thanks, everyone.